Okay. Very good evening to all of you. Myself, Dr. Rachit Sharma, working here as a consultant in Arab Medical College in Lucknow. So the today FB live session is about the COPD, which is Chronic Obstructive Pulmonary Disease. If we talk about the global burden of COPD, we can clearly see how the major issue, what is the major issue going here is that COPD accounts 391 million global cases, out of which 55.3 million are the Indian, which accounts about 21.98% overall burden in India. So India ranked among the first in the prevalence. If you talk about the deaths, there are 2.9 million deaths occurring globally, whereas in India it occurs about 8,48,165, which accounts 28%, almost 29%, and India ranks second in the death. If we talk about the daily, we can see that globally there are 63.4 million cases, and in India there are 22.4 million. With percentage, if you talk about the percentage, it is about 35%, and India again stand on the first position. So this is the global burden of the COPD. COPD is one of the leading causes of morbidity and mortality worldwide. Now, about what is the burden of COPD in India, as we can clearly see that the cause of the total number of deaths in India is the second in the total cause number of the death in 2019, whereas the third in the cause of death and disability in 2019. This has been data taken from the www.healthdata.org in India. If we talk about the burden COPD in India causing status, we can clearly see how the burden has increased, mostly in the Jammu Kashmir as well as Punjab, Haryana, Uttar Pradesh area. What is COPD? According to the Gold Guideline 2022, the COPD is a very common, preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to the airway and or alveolar abnormalities, usually causing by significant exposure to noxious particles and gases. Basically, it is a 2022 definition, and there is slightly change of words in the 2023 latest guideline, which have came 3 or 4 days back only. What are the risk factors for COPD? Age above 40 years, basically in the elderly patients. Smoking, we can clearly see. Exposure to biomass smoke, mainly occurring in the females in the village population, or you can say in the rural areas. Occupational exposure, recurrent lung infection in long-standing asthma, and air pollution, which is the most concern point of the risk factor of the COPD. Some COPD facts from India. That in India, first 1 into 3 COPD patients have never smoked. That means that non-smoker also is having sharing more percentage of COPD. 46% of COPD patients were exposed to biomass smoke. 85% patients feared worsening of symptoms due to weather changes. 89% patients visited the doctor for worsening of the symptoms. Every 1 in second COPD patient get hospitalized at least once a year, mostly in the winters. If we talk about the symptoms of the COPD, most common symptom dyspnea, which is progressive over time, will become worsened during exercise, and it is persistent. Chronic cough, recurrent wheeze, may be intermittent or unproductive. Chronic sputum production, any pattern of chronic sputum production leads to, these are the main 3 symptoms of the COPD. If we talk about the pathophysiology of the COPD, we can clearly see about difference between the diagram showing the healthy lung and the diseased lung. First, chronic bronchitis, which is clinically it is a condition where there is a presence of cough and sputum production for most days over 3 months or 2 consecutive years. Secondly, emphysema. It is destruction of the alveolar walls and loss of alveolar elasticity. If we talk about chronic bronchitis, so this is the lumen of the healthy individual, and in chronic bronchitis, which occurs due to smoke, indoor pollution, outdoor pollution, which causes irritation in the whole of the bronchial tree, leading to the inflammation and excess of mucus formation, due to which the lumen start getting decreasing, and the diameter of the lumen can decrease. Therefore, there is a limitation in the airflow. See, you can clearly see the diagram showing the wall have become inflamed. Smooth muscles which are relaxed in the normal individual now has become tight, and the air start head trapping in the alveoli. So these are the changes which occurs during the pathophysiology of the bronchial tree, which leads to the recurrent lung infections. If we talk about the emphysema, you can clearly see the healthy individual, there is healthy alveoli when a person get exposed to the chronic cigarettes and all, which leads to the harmful particles get trapped in the alveoli, causes inflammatory response which get triggered, causing neutrophils, macrophages, increasing the production of the elastase, which cause destruction of the alveolar walls, and air trappings head start, which causes the emphysema. So this is the difference between emphysema and the chronic bronchitis. Again, in this you can clearly see in the normal lumen, the airway held open during the alveolar by the alveolar attachment. But in COPD, there is a disrupt alveolar attachment leading to emphysema. Mucosal inflammation and fibrosis occurs. Mucus hypersecretion occurs. Therefore, the airway is obstructed by the loss of attachment, mucosal inflammation and fibrosis, and mucus obstruction of the lumen, which again causes the narrowing of the lumen. Destruction of these alveolar walls decreases the lung elastic recoil. Enlargement of the alveoli reduces the maximal expiratory airflow. What is hyperinflation? See, you can clearly see this is a normal lung, normal curvature of the diagram of the diaphragm. In the second, you can see this is a hyperinflated lung, and due to the lung has become hyperinflated, the diaphragm has shifted downwards. Therefore, the flattening of diaphragm is seen basically in the COPD patient. It is about less than 1.5 centimeter on chest X-ray. Now, the devices such as spirometry is useful for diagnosing. This is a device, a spirometry device. It is a gold standard test for confirming the diagnosis of asthma and COPD. A test that measures how well you can exhale. If you talk about the spirometry parameters, first is FEV1, that is forced expiratory volume in 1 second. The maximum volume of the gas which can be expired from the lung in the first second of the forced expiration from the position of full inspiration. Therefore, this is known FE1. It is decreased in the COPD. And FVC, which is forced vital capacity, it is the maximum volume of the gas which can be expired from the lungs during a forced and a complete expiration from a position of full inspiration. Therefore, again, in the case of COPD, FVC is also decreased. Both FE1 and FVC get decreased during the COPD. It is required to make a diagnosis. The presence of the post-bronchodilator, that is FE1 by FVC, should be less than 0.70, which confirms the presence of persistent airflow limitation, and thus patient shows the diagnosis of the COPD. Or more than 12% or 200 ml reversibility. What to look for the spirometry? First, post-bronchodilation of FE1 by FVC less than 70% indicates the COPD. Second, predicted FEV1. What is the predicted value of the FEV1? We have to look. Now, this is a diagram, a spirogram you can see of first showing of a healthy individual as well as the COPD patient. In this, you can clearly see that patient have to exhale his air out about to 6%. In the first second, FEV1 is about 4 liters and FVC is 5 liters and FEV1 by FVC is 0.8. So it is a normal. If you talk about in the case of COPD, you can see how the FEV1 has decreased from 4 liters to 1.8 liters. That the patient has not able to only have expelled 1.8 liters of air through his lung. And FVC have also decreased to 3.2. And the ratios have been also decreased to 0.56. So this is a graph showing an obstructive pattern. What are the practical issues with spirometry? First, limited access to the spirometry. Need frequent calibration. After every 3 or 4 spirometry, you have to need to calibration of the machine. Third, it is costly. Fourth, it requires a trained technician. the more the technician is trained, the more the great values will be, he will be able to counsel the patient, and good FE result we can see during the spirometry and the time consuming. Now this is a macrospirometer. It is a portable one. It is a portable spirometer which can be used as a screening tool for COPD. Basically, it is used for screening. It includes a questionnaire using IPC-RG questionnaire. Second is the FV1 by FVC, FV1 by FV6 using COPD 6 or PICO 6. What are the advantages of macrospirometer? First, it is simple, handy to use, and easy to use. Second is it is a very handy instrument. Third, it is economical. And fourth, it does not require a training and validation. What do we get in macrospirometry? First, FEV1. Second, FEV6. Third, FEV1 by FV6. And fourth is the lung age. The IPC-RG criteria questionnaire should be more than equal to 17 points. FEV1 should be more than equal to 80% predictive value. FEV1 by FVC should be more than 0.8, that is 80%. Asthma and COPD are not the same, as we all know. Reversibility is seen in asthma, but not in COPD. If we talk what is the basic difference between asthma and COPD, first is the age. Asthma can occur in any age, whether since birth, after 2-3 years, till the, you can say, late onset asthma and all. And COPD usually occurs after the 40 years. Nighttime awakening is present in asthma, but it is not so common in COPD. Smoking may not be associated with asthma, but yes, COPD, maximally it is present. Cough in asthma is usually episodic, and in COPD is throughout the day. As you can see, the chronic smokers, people are always coughing throughout the day. Airflow limitation, it is episodic, reversible. In COPD, it is progressive and not fully reversible. If you talk about the predominant inflammatory mediators, we can see in asthma, it is eosinophils, but whereas in COPD, it is neutrophils and macrophages. If you talk about the diurnal variation, it is very common in asthma, but in COPD, it is not. First line of treatment, yes, it is obvious. It is in asthma, we gave inhaled corticosteroid, but in COPD, we need inhaled bronchodilators. Past history of family history, yes, history of allergy, childhood asthma, or family history of asthma is present in asthma cases, but in COPD, history of exposure to noxious particle gases, mainly tobacco smoke, biomass exposure, smoking, etc. These are the various factors which we can see in the history. Time, of course, often improves spontaneous with or without treatment, and COPD is generally progressive over a period of time. Common spirometer variable used for diagnosis is bronchodilator reversibility test. Post BD increases FE1 by equal to more than 12% of 100 ml from the baseline. But in COPD, it is post bronchodilator ratio FE1 by FVC less than 0.7, which confirms that patient is having COPD, not asthma. What is the approach of diagnosis and management of COPD? First, assess the severity of the disease, assessment of the symptoms, and assessment of the risk of exacerbations. Now, this is the stage-wise classification of the COPD severity, which has been divided into 4 stages: mild, moderate, severe, and very severe, depending upon the FE1 by FVC, if patient is having 0.70. So in stage 1, that is mild, we can see that FE1 is more than or equal to the 80% of the predicted value. In stage 2, the FE1 is 50 to 80% predicted, and whereas in stage 3, FE1 is 30 to 50% predicted. And stage 4, which is known as very severe, the FE1 is less than 30%, which is quite dangerous. Now, the management of stable COPD. First, self-management or education or smoking cessation, pulmonary rehabilitation. These are the various self-management and educate the patient, stop the patient, ask the patient to stop smoking is required. Second, give him a good bronchodilator along with inhaled corticosteroid. Pulmonary rehab plays important role. Then oxygen therapy, and last, if patient not improving, we need a surgery. So therefore, it increases the severity of the disease as we go down. Now, initial pharmacological management, it has been divided into 4 groups, A, B, and C, and D. I think it is an old goal 22. Now the now there has been a change that C and D group have been gone. Only group A, B, and E is left. So let's talk about this old goal to 2022. In group A, we need a bronchodilator. And in group A, only those patients occur whose MMRC grading is 0.0 up to 1 and CAT score is more than 10, and 0 or 1 moderate exacerbation. In group B, the MMRC grade is more than 2, CAT score is more and 0 to 1 moderate exacerbation occurring. No leading hospital administration. But in group C, we can see there are more than 2 moderate exacerbation or more than 1 leading to hospitalization. And MMRC grade is between 0 to 1 and CAT score is less than 10. If we talk about group D, we can clearly see the MMRC grade has also increased more than 2, CAT score has also increased more than 10, and exacerbation has also increased more than 2 in moderate. So in group A, which is least, we can clearly see that we need to give a simple, a good bronchodilator. Whereas in group B, we need a long-acting bronchodilator. We can give either LABA or LAMA, that is long-acting beta-2 agonist or long-acting muscarinic agent. In group C, LAMA is enough. And in group D, LAMA or LAMA plus LABA or ICS LABA, or we can give a triple drug therapy also. So this is basically an old goal 22. In new one, it has been slight change in which group A, B, and E is now. And bronchodilators are central to a management to COPD therapy. Therefore, we can clearly see if inflammation and oxidative stress and tissue repairs, there is an expiratory airflow limitation, which causes hyperinflation, causing dyspnea, which inactivity and deconditioning leads to decreased exercise capacity and decrease in impairment quality of life, and finally death. And the patient who are having not on bronchodilator goes to recurrent exacerbation. So we need a bronchodilator just to increase the expiratory flow limitations. So there are various types of bronchodilators available, such as beta-2 agonist coming with spacers, inhalers, and other is anticholinergic. If you talk about beta-2 agonists, there are short-acting such as salbutamol, levosalbutamol, and long-acting are salmeterol, formoterol, indacaterol, leading to 24 hours mode of action. If we talk about anticholinergic, there is a short-acting ipratropium, and long-acting there is a tiotropium, glycopyrronium. Again, it is a ultra-LAMA. COPD exacerbation, an acute worsening of respiratory symptoms that result in additional therapy. Exacerbation negatively impacts the health status, rate of hospitalization and readmission, and disease progression. Exacerbation are a matter of life and death of COPD patients. Now, how to classify we can say classification of exacerbation. Type of exacerbation, they have been divided into mild, moderate, severe. If treated with mild, we need only short-acting beta-2 agonist. In moderate, we need short-acting beta-2 agonist along with antibiotics or oral corticosteroid. But in severe, patient required hospitalization or had to visit an emergency room of an hospital or a clinic, in which we need a short-acting bronchodilators. What are the symptoms of exacerbation, which indicates that patient is now having exacerbation of COPD? First, increased coughing, increased dyspnea, and increased sputum production and change in the color of the sputum. You can see the disease trajectory of the COPD patient with exacerbation. If a patient is on bronchodilator or patient is having no exacerbation, you can clearly see how the rate of the decline of the deterioration of the lung. But if you are seeing that number of exacerbation will increase, and so with the increase of number of exacerbation, there is a more deterioration of the lung. Every time the exacerbation is there is a steep fall in the lung deterioration of the lung functions, ultimately leading to the end of the life. Now, if we talk about the COPD and comorbidities, they are the first is, if you talk about heart, there is the cardiovascular diseases and musculoskeletal, we can see osteoporosis, patient leading to anxiety and depressions. That patient feel more dyspneic, not able to go outside. So he started becoming in the phase of depression or anxiety. GRD, lung cancer, and diabetes. These are the common comorbidities conditions associated with the COPD. Now, the key points for the use of non-pharmacological treatment. First, education, self-management, and pulmonary rehab. Education is need to change the patient knowledge, but there is no evidence that is used alone and it will change patient behavior. Education, self-management with support of a case manager or without use of the written action plan is recommended for the prevention or exacerbation complications such as hospital admission. Again, it is in evidence B. Rehab is indicated in all the patients with relevant symptoms or high risk of exacerbation, having a great evidence A. Physical activity is a stronger predictor of mortality. Patients should be encouraged to increase the level of the physical activity, although we still don't know how to best ensure the likelihood of the success. Second, vaccination, most important. Influenza vaccination recommended to all the patients with COPD. Pneumococcal vaccination, that is PCV13, PCV23, are recommended for all the patients more than age 65 years of age and in the younger patient with significant comorbid condition, including the chronic heart or lung disease. COVID-19 vaccination, the line of national recommendation is there. Now, Tdap vaccination for adults with COPD who are not vaccinated in adolescents is to protect against the pertussis of whooping cough. Now, nutrition supplement. Nutrition supplementation should be considered in the malnourished patient with COPD. End of the life and palliative care is important. All clinicians managing patient with COPD should be aware of the effectiveness of the palliative approach to the symptom control and use of these in their practice. End of the life care should include discussion with the patient and their families about their views or resuscitations, advances, directives, and the place of the death preferences. Thank you. So this was my presentation on the COPD.